Hello, everyone, and welcome to our Biomedical Informatics and Data Science Grand Rounds. My name is Paul Naji. I'm the program director here for our graduate training program, and I am excited to have a good friend and a special guest today performing our Grand Rounds. As you know, this is our monthly Grand Rounds series. We want to encourage people we would bring in leaders from across the field who are really paving the way forward for biomedical informatics and how it's being used in clinical, in educational areas, as well as in research areas. And so today we'll be talking with Andrew Williams, and we want to make sure that you are actively involved. Please feel free to submit questions during the lecture in the Q&A window in the Zoom link. Or you can wait till after the end. We'll try to leave some time at the end of the lecture for some questions as well. Dr. Andrew Williams received his PhD at the University of Hawaii at Manoa in clinical psychology, and has really built his career on observational health methods in distributed networks, biostatistics, and biomedical informatics. He is the co-leader of the Tufts CTSI Informatics Core and assistant professor of medicine at the Tufts University School of Medicine, and professor of the practice in NU's Boise College of Health Science. And so I work with Andrew, and together we serve on the steering committee for Odyssey, where he also serves and co-leads several other Odyssey working groups. He co-leads the Tools and Resources and Observational Medical Outcomes Partnership and Open Biomedical Ontologies, OMOP to OBO in short, domain teams in the National COVID Cohort Collaborative, N3C. So he's a close colleague with many of us here at Johns Hopkins. And today he's going to be sharing about how OMOP is not a static data model and how we're extending that OMOP data model to address new research opportunities here in biomedical informatics. Andrew, thank you so much.
Thank you so much. It is really a distinct honor to be talking to people here at Johns Hopkins who are doing so much to advance the kind of work that I'm going to be talking about, both in their own institution there and all the centers of excellence that you all support, and as national thought leaders, and in the Odyssey community and in the National COVID Cohort Collaborative. It's just been a fantastic experience to be working with many of you in all of these different contexts, and so pleased to be able to describe a little bit about what people I'm working with at Tufts have been doing. Some of the stuff I helped to lead that Paul has mentioned. I'm going to leave out some other things that are near and dear, I think, to all of us. Some work that I think has been covered in previous talks by Asia Golazar. So I'm very involved in the oncology work group, and my colleague Robert Miller in the mapping of data from tumor registries, the NACER standard for tumor registries, to OMOP and tooling associated with that. Other work on learning healthcare systems, particularly linking OMOP-related analytics to a FHIR resource so that you can take advantage of the hooks into EHRs for communication to have a greater impact on care from research analytics. Other things I'll be leaving out. I'll just going through a select set of areas in which, as you were saying, Paul, we've been working on expanding the kind of data and to some extent the kind of analytics that can be brought within the sphere of the Odyssey ecosystem. And I'm going to make sure I can advance my screen. Here we go. So I think most folks have a pretty good idea of what Odyssey is, but very briefly, it stands for the Observational Health, Data Science, and Informatics Community. There's an excellent website and a living document in the form of a book that describes the essential features of what's going on. It's a vibrant global community, and it is in some ways the answer to this question of how do you make use of the ocean of data generated every day in healthcare settings to improve health outcomes. Obviously, there are many efforts that do that. Odyssey has its own take on it, and its answer is to develop an open science community dedicated to improving health decisions by using a CDM and related tools to conduct large-scale research, very much as other federated networks and pooled resources like the National COVID Cohort Collaborative, or all of us also do. It's got its own distinct features, but I'll go into unpack very quickly some of the things that are implicated in that answer of building such a community that does those things. It means making data interoperable across institutions by mapping whatever our local representations of data are to a common standard, and doing that in a way that is database agnostic, so that if I am in London and want to do research on atrial fibrillation from prior to 2019, when they were still using read codes for billing of and diagnosis codes there for billing, and I want to do that with folks in Maryland, and I want to do it with folks in Korea, we all have to map our various ways of representing what atrial fibrillation looks like in our own institutions to a common standard. And it's best if we set that whole thing up so that the tools are database agnostic and expect the data to be in that standard and design them so that they implement best practices. And one of the other things the Odyssey community has been cutting its teeth on, making a name for itself in, is in comparing different methods for doing some of the major work involved in using large-scale real-world data, how to do covariate balance properly, how to take care of residual confounding, lots of other important tasks that really affect the outcome, and then implementing those in this tool stack that expects your data to be in that format. But even after you've done that, you will have nothing at all other than a bunch of schema and well-developed code set. You really, in order to make the whole thing happen, you have to motivate, train, and support people around the world in order to get them to transform their data, extract, transformation, and load their data into that common data model and use it collaboratively to conduct studies. And in the case of the Odyssey community, there are 3 broad classes of studies that are supported. Characterizations. There's some very large scale characterizations done by the Odyssey community, for example, on all first line treatments of hypertension. We're involved in doing one on 4 different types of cancer. But that reveals the differences regionally within the United States or around the world in what first line treatments look like, second line treatments, and so on, and set the stage for comparative effectiveness research of the different therapies that are used in those populations. And then there's a very well-developed pipeline for doing prediction studies, either for diagnosing patients, given all the information that's understood about them, or for predicting their outcomes or risk of certain outcomes. And this is the common data model that the community uses. This is the 5.4 version. And over on the left-hand side, you see all the clinical data. Those are the data that are in an institution. The key things to pay attention to are that it is person-oriented. It is the people that have any records in whatever sources you've brought into the EHR, into the OMOP CDM, are there along with their demographic information. But they have visits, and you'll see all the different arrows going from visit, the bent blue arrows visit, to all the other sorts of things that happen at those visits. People are given diagnoses, their drug orders, procedures are given, measurements are taken, other things are observed about them. And so you have this basic relational structure over time of people having visits and all the things that occur to them. And then in the middle, the key part there in gold is the standard vocabularies, and all the lines there show that those vocabularies, those standard mappings that we were talking about before, annotate all of that information that you've got in your data source and allow you to take advantage of the hierarchies in those vocabularies, things that subsume more granular representations of a medication and its ingredients, or of a condition and the subtypes of that condition, etc. And to build concepts sets and to bring them together to form cohorts and use the Odyssey tooling to feed those cohorts into pipelines for doing the different kinds of studies, the characterization studies, the comparative effectiveness research studies, and the prediction model development and validation studies. When you do that, some of these tables over to the right come into effect. So once you've brought together the different concepts for this drug and that procedure and this condition and defined a particular cohort, then the results schema will contain a sort of a skinny table with a list of patients who meet that cohort definition for the defined period of time. And I'll have details about the cohort definition itself. That then goes in and extracts the data from your backend, from the backend database where the data are stored, and feeds it into the R or Python or other analytic tools that are a part of the Odyssey tool stack. That all is typically packaged up in a very short form, maybe as few as 20 or so lines of R code in some cases, but tons of functionality on what those cohorts look like and characterizations of the entire data set that gets extracted and all of the assumptions for the analytic routines that are employed and the actual results themselves all get output from those 4 lines of code that string together the different pieces of the Odyssey tool stack. And that is shared typically in a federated setting with data partners around the world, and the data results are aggregated to do the study. That's how that CDM gets used. And typically, the sources of data that are used are, as we said, the demographic information, patients' age and their sex and their race and ethnicity, and doing to the origins of OMOP in a pharmacovigilance study where the partners in Europe and the United States mostly had insurance claims data. The focus was on those coded vocabularies available in Europe and the US for conditions, for drug orders, for labs and procedures. And then as the data model evolved, more EHR specific data on lab results, miscellaneous observations from flow sheets, vital signs data, et cetera, and increasingly data extracted from unstructured sources, but coded in these same standard terms and in the appropriate clinical tables have been a part of what is available and used in Odyssey studies. But here I'm going to, as I said, as Paul mentioned, go through some of the work to expand on the kinds of data that can be used and address some of the gaps that are there. And this is in order to really do what might be called deep phenotyping. That's not, there isn't a universal definition of what people mean by deep phenotyping. I think in general, they mean to more precisely define populations exposures and health states using richer data sources in one form or another, and augmenting what is typically available in various ways to deepen the characterization one has of any of those things one is developing a computable version of for studies. I think the time I'm going to have is sufficient for me to cover everything. And so I think most people have a pretty good sense of what Odyssey is, the overall strategy, and so on. I just want to pause and make sure people who don't understand some of that background have a good sense of the context of what it is we're talking about here. Does anybody have any questions about that?
I think we do. I think you're actually absolutely right. And a lot of our clinicians are struggling with this question of deep phenotyping, because you're right. The main facts that they want are in OMOP, the labs, the meds, the procedures, the diagnosis codes. But then the key features that they build in their Epic flow sheets are often not. And so, or there's one piece that's missing and also, they're trying to find new biomarkers for progressing disease. So I think this quest for deep phenotyping is going to be a staple that we need to constantly be looking at to enable biomedical discovery.
Yes, very much as you are doing in the imaging work group, and Joseph Murray and other people are helping with the genomic work group, so on, and very much you all are contributing to this effort to enable us to do that. And the answer to how to do this in general is to standardize these other sources like imaging or genomic tumor profile data or other kinds of data so that we can get this richer, more detailed characterization. Sometimes it is, as very much you say, in flow sheets. Other times it might be in your PACS system or coming through some of the next generation pipelines for tumor panels and so forth. So I'm going to go through here on this slide just quickly the broad categories of the things that I plan to touch on in the rest of the talk, and starting with enhancements to patient demographics, for example, social determinants of health in the electronic health record, measures of physiological processes, for example, waveforms that you might get from an electrocardiogram or electroencephalograph, or other data that are coming out from various devices and monitors and telemetry. Other measurements that are often used in routine care that give you this more precise characterization. I am a clinical psychologist and have a strong interest in getting a finer grained understanding of the phenomenology of mental health, behavioral health issues than one gets from a simple diagnosis code. And so neuropsychiatric scales and subscales and the scores that you get from applying them to patients and their interpretations are another area we've been working on. And exposures outside the clinic. So one of the Odyssey work groups I co-lead is called the GIS work group. It's really about place-related data, very broadly defined, including social determinants of health for regions rather than for individuals, environmental toxins that you might get from sensors in the environment or from, that are collected by municipalities. Other things like distance from care that are inherently about the geography of where people live and affect their access to care, we know is extremely important. So a very broadly defined sense of what place-related data means and how to bring those in relationship to the other clinical data to include those in analyses. And we'll start off with enhancements to patient demographics. They're one of the things that has happened relatively recently, is still in progress, is a proposed revision to the OMOP vocabularies for race and ethnicity. The link to that proposal, which has been discussed and is continuing to be discussed in the OMOP CDM's vocabulary subgroup, which I'm a part of, was proposed by Jake Gilberg, who up until recently was working with me at Tufts. I helped a little bit. It was really mostly Jake's baby. And it's there for comment. And it's an important area, obviously. It's something we really need to get right. And your contributions to that and comments on it would be helpful. Devira Gabriel has been a key member of that group, speaking of the contributions of Johns Hopkins, about how we're managing all of the processes about revisions to vocabularies, in general, professionalizing the whole way in which the Odyssey community and OMOP has been handling everything to do with proposed additions to, amendments to, and versioning of vocabularies, given her excellent experience at HL7 and elsewhere. It's been a wonderful contributor there, and she's been a part of these initial discussions around this. There has also been work done in the Odyssey Health Equity work group, and almost a fusion between that work group in some ways and a lot of the key members of the National COVID Cohort Collaborative's SDOH domain team to identify the data that are typically captured. This is, I think, relied a lot more on the N3C data than it has on contributors from the Odyssey community, and a lot of great work by that domain team on seeing what are typically available and work on mapping what's typically available where there are existing standard concepts. So things that are either in LOINC or in SNOMED that could be God, and it could be added to the ETL, the extraction transformation load code that institutions write to bring their source data into the CDM. And that's been very productive work. Jake Gilberg, again, helped to organize and lead this whole effort around the health equity work group that included bringing in a lot of folks from N3C and their domain team. And in addition to that, seeing what's already there, convened what I thought was a very useful, and I hope to see it revived, effort to kind of do a little landscape analysis on what's happening in the space of ontologies for social determinants of health. There is a very important effort called the Gravity Projects influencing that, but there are other efforts as well. And I think some, because it's a space many people are interested in, many institutions are interested in, for very excellent reasons, and coming to some kind of consensus about how those ontologies ought to be structured, both given what data are typically available and how they conceptually ought to be related to one another, is an important topic. My sense is that there's a lot of work to be done yet in that space. I think the upshot of, as I understood it, of that, what happened when those people and efforts were convened was that there was fairly different approaches in character and in method to coming at that problem of coming up with a standard ontology for social determinants of health. And so I think that's an area where people could contribute that would make a big difference. There's also the beginnings, and really just the beginnings of some thinking about how to handle both the individual level social determinants data that you might get from questionnaires that are administered in healthcare settings to individuals, and equivalent place-related data. So data affecting people's ability to pay might be gained from them in a question to them as an individual, or inferred from knowing something about where they live and their employment status, or other common metrics that are calculated on regions in the census or elsewhere. And how does one deal with that? How can we leverage one to understand the domain and proper domain and value of the other, et cetera, as well as just mechanically, how do you equate vocabularies that might look different and understand their conceptual relationship to one another properly, given that they are about different kinds of entities and used in slightly different ways. So that's another area we're started to think about, but haven't done really a ton more than that I think will also have a big impact on this very important fundamental feature of all the data we deal with, which is just about the patients themselves from a demographic point of view. Some of the use cases that are driving that work, and in general, the strategy in the Odyssey community in particular, is to never really take on a major task like modeling a new data domain in the absence of motivating use cases. It's used in many different areas of development, but it's pretty assiduously adhered to in the Odyssey community. So things that theoretically ought to be important, but you don't really have a pressing need to get something done that requires that is it's going to get less attention and support than something that has a pressing need. So the use cases that have emerged in the work that I'm been in any way associated with are some community-driven efforts. So our engagements with members of the community and with whole communities in the Boston area that are interested in understanding and addressing social determinants of health and reflecting the needs that come out of that understanding and what the institution is doing, and motivating research that helps drive policy that address those things. There's various excellent groups at our CTSA, as I imagine there are at Johns Hopkins, that have been engaged for a long time with community members and trying to understand those things, and some collaborations are starting to emerge around child and maternal health, access to and use of mental health services in the Chinese community in the area right around Tufts Medical Center. There's also, as in many areas, a strong interest in investigation of bias and prediction algorithms as they affect vulnerable and underserved, underrepresented populations who are, if you define those populations in terms of their demographic attributes. And some interesting and intriguing initial work on strategies that might be used to address those biases using synthetic data. So we've developed a synthetic version of our OMOP data warehouse, or a synthetic derivative of it, with a startup commercial partner, and exploring various ways in which essentially the model that's used to generate the fake data patients that company has devised could be used to, for example, correct over or underrepresentation of some groups in ways that would make a prediction model more likely to be in error when making predictions about members of that group. So if the model has a good enough representation of that subgroup, you can just make sure it isn't underrepresented by artificially producing more of them, for example, as a particular strategy. And then there's another use case about examining whether there are disparities associated with different demographic attributes for waiting times in cancer surgery. That's going to be the pattern. I hope this is useful, where I kind of cover this broad area, in this case, demographic data, kind of say in general some of the stuff that's been happening and what some of the use cases are that are motivating it. So if this pattern is going to be repeated for these other areas that I named at the beginning.
Yeah, this is really helpful. I mean,
that's helpful.
In terms of health is incredibly important. Are you getting it directly from your EHR?
We're getting it both. Yeah. So, and I think institutions, my understanding is that we are not unique, and the other institutions that we know anything about are not unique, and it being very hit or miss as to how assiduously the capacity to ask about social determinants, housing security, all of the different kinds of things that there are standard fields for, standard measures of, is very hit or miss and somewhat capricious. And I think it takes, it's an area where I think alignment with some of the things that are reviewed by leaders in the care delivery institution in their mission statements at annual meetings and so on, where they say, what are we doing on this, and how well do we understand whether we're meeting our goals on it? I think getting it into that space and metrics derived from it, and the problems with the completeness of data in front of them, to me seems like an appealing strategy, because it is, at least I've heard from many people in many different institutions, something where you only get a subset of clinics or kinds of types of patients where these questions get asked. And so when you need anything that looks like a more comprehensive assessment that uses those tools that are available in the EHR, it's hard to find.
Yeah, because this requires a lot of clinical training to ask new questions about economic security and housing and things like that. But you are getting probably from the EHR the patient's address for GIS location to determine if they're living in a food desert, right?
There's a lot of things that you can't even get in principle, as you're saying, from those standard questions. Yeah, I think my point was a little bit different, but you're absolutely right, that the ability to get things from place-related data, what's known about social vulnerability of the place where the person lives, if you combine all the different attributes as people developed algorithms for, that says things that turn out to be highly predictive of health outcomes about those regions, then that's very informative, potentially very informative clinically, and is, in principle, not even the kind of thing that people are trained to ask. I was saying more that it would be great if we got more individual level data on those same things like housing security. And I'm not sure how hard they are. It's certainly going to be relatively unusual for lots of MDs to dwell on that in precious time that they have. I think building them into standard workflows in the same way that other kinds of questionnaires often are, other kinds of questions and interviews that are done for medical history and review of systems and so on in various settings. I think it's not a stretch to see a choice set of SDOH questions added to that list of things that are gotten on a routine basis from lots of patients. And I think we should aspire to that. But your point is well taken, that there's other ways to get that data and other ways to get other kinds of data that are also very much about the social determinants. So the next type of data we're going to talk about is physiologic signal data. Many features of these data already have a place in some standard vocabulary that's used in OMOP. You might have the ST amplitude from a ECG read out from an ECG machine into its bespoke database, and there's already a LOINC code for it. It might not be coded, but it's you would get the label for it from a lot of machines, and it's relatively easy to do some mapping from that if you can actually get it from there. So there's a real opportunity to get a lot without any new work in some sense. But there are some important challenges. And that applies to not just ECGs, EEGs, but all kinds of data that are routinely brought in from medical devices. And so that's good news. But there are some real challenges to capturing the data. It's often voluminous and not automatically saved. The important clinical gist of it is saved, and there's some typical processes for validating what's been brought into an EHR if it's been brought in automatically from some sort of system. It's not always clear once that's there exactly when is obtained, and often there needs to be extra work to actually link it to the patient and the bed and the time that relies on excellent and standardized practices by nursing staff and others to accurately capture that data and check on it and make sure it's accurate. And so automated solutions are really very helpful where that isn't required, because it's a busy space. And if it isn't clinically essential, if the clinically essential information is already obtained, and it's not uncommon for that to be hard to do that linking and to get even make use of the data that has been captured if it isn't linked correctly. Once one has it, you can parse it, annotate the features, identify artifacts, either in an automated or semi-automated way, and use what's been annotated for all the purposes that you would want to use it. People to define people who have certain characteristics, to come up with all the different features for a prediction model, for all the different kinds of things you would want to use these data for. It is voluminous, though, and figuring out the right amount of it, chunking it in appropriate ways, has its own challenges. In the ICU, for example, there are days worth of data from many devices, and there's a tremendous amount of redundancy in there, but there's some really meaningful periods of change. So identifying when those are, sampling so that you've got a sufficient amount of the data from those epochs within that data stream that occurred over several days for a particular patient, and get that change when it happens and divide it up into meaningful epochs. All of that is work that we are trying to develop approaches for. And we have strategies for doing that. I don't think it's a finished product yet. It's particularly for integration into OMOP, which wasn't designed to take millions of additions to a measurement or observation table, and add them per device, per person, per day, you have a real choice to make about what should go in there, what's needed to actually define your cohorts, and when you can make do with a link to the original data for more complete analysis by some algorithm that's designed to, for your algorithm development work that's designed for those specific waveforms or other high resolution data.
Andrew, quickly, so do you know, are there any regulatory requirements for saving waveform data? Like in medical imaging, we are required to save it because it's a legal record, and that gives us a lot of advantages for having a good clinical archive. I think one of the challenges we have with waveform data is we don't have clinical archives of this high resolution frequency data in a standardized location.
I'm certainly not aware of any. In all the different work that I've done on this, that's not come up as a requirement. It's always happened where there are archives, they're being saved in a very short-term way for review in case something was missed for a reasonable period of time where the patient decisions about the patient are still in play, and then disposed of, unless there's some research interest in preserving them for longer periods of time, but nothing that's been motivated by mandates in the way they are for imaging. So not sure I want to advocate for more government regulations on things, but I could see how that is a benefit in the imaging space, but there's nothing there that I'm aware of.
I think anywhere there's data that a diagnosis is being made off of, there could be an argument that data should be preserved if it's sufficient for a diagnosis.
Yeah, you're absolutely right. There's an excellent argument for it, and certainly diagnoses are being made on this, and so it's possible that I'm just ill-informed on that question. I should say I'm not aware of any.
I'm not aware of any. I'm not aware of any either. So I think you're most likely right. I don't know if you want to describe what you set up at Tufts for connecting from different device networks, because I think we are seeing now a lot of efforts to bring these signals together into one place. One is just for the sanity of the ICU staff to manage alarm management, to have a better holistic view of the patient, but it's kind of giving us the opportunity to also think about more centralized archiving. So there's definitely a centralization going on in the ICU right now.
I do want to talk about it. So data capture at Tufts Medicine. And this is not a plug for the capsule solution that we use. This is simply a description of it, and a very bare bones description at that. The main thing that it's important to note is that it solves the problem I described earlier of relating patients' data to the patient and at a particular point in time, and helps automate getting versions of it in HL7 messages into Epic. It also allows you the options to get higher resolution data to another source to direct it, again, using HL7 or other output mechanisms. And so that's a good feature for us. It essentially sees those different devices as a feature of the room, so that when a person is admitted to that room and that bed, it is automatically associated with them and time-stamped in ways that are very useful for us. And these are the kinds of data that we're getting. So it's a broad set of devices: anesthesia machines, balloon pumps, ventilators. I won't read all of them, but more than 1,000 devices across the different institutions that make up Tufts Medicine. We're in the process of completing a transition to Epic that happened a couple of months ago. And we took that opportunity to not only consolidate with the other institutions that make up Tufts medicine beyond Tufts Medical Center, but to unify various aspects of how information flows happen and how support for research happens and other kinds of good things. And one of those is in how we're working with devices, both for unique identifiers for devices and for data from devices. And that's the context for this solution. So we're at a good point of being able to capitalize on this new, more unified approach, not only at our institution, but across the others that make up the parent entity of Tufts Medicine. And it's important to note that as much as we want to do this in the Odyssey community and in the National COVID Core Collaborative and do it using OMOP, there's a fantastic precedent set by all the work that's been done for a long period of time by folks at Beth Israel, their data being given to people in Roger Mark's shop at MIT, and the development of the MIMIC data set and the entire PhysioNet community. So there's a large, flourishing, productive open science community using that data source, and all kinds of tools that are predicated on the data being in the format, the waveform database format, the WFDB format for its waveform databases. So there's things that visualize those, allow them to be annotated and dealt with in an efficient way, and whole sets of practices that are really, it would be kind of crazy to just let go of and reinvent wholesale. But other aspects of the MIMIC framework are not as advantageous as having a really well-defined common data model. Not only can you not use all the other things that are designed to work with OMOP, they're just idiosyncrasies because it wasn't set up to be a common data model. It was set up to kind of partially normalize the fairly idiosyncratic structure that the data was originally transmitted from Beth Israel to Roger's shop. So we did a MIMIC to OMOP project that took the most recent version of MIMIC, which is MIMIC 4, and mapped it to the OMOP common data model and included a strategy that tries to meet some of those challenges I was just describing above. And this is really Manlik Kwong's work. This is a description of what he has done in that project and work that is going to be pivotal in a new Bridge to AI proposal project that's been funded that will go across 14 different CTSAs. We at Tufts are going to be running the data standards module for that. But tooling is going to be built for it, and it will produce a large critical care data set that includes data from many different modalities, and eager to make the advantages of OMOP Odyssey tooling and contributing to it and expanding on it a key to what we do. So, and there's so appetite for that. The more people are learning about it, the more enthusiasm there is. And Paul, as I've mentioned, I'm interested in introducing you to the folks who are leading the imaging work so that can be on the table for them to consider. And this flow essentially shows what Manlik did in this MIMIC to OMOP project, taking the waveform database files. He used XML. He has something he wrote that takes the header information and other information from the waveform database format of a waveform like a EKG reading, splits the data, normalizes segments of it, annotates it, and does some further processing in a couple of different formats down to CSVs, and reintroduces the OMOP metadata, and then allows it to be imported into an OMOP CDM database at the end. Some of the lingering questions are the ones I described. He's come up with some interesting strategies for trying to say, when is there a break in this, many hours worth of data, to say, here's something new here. We should be starting to sample data at a higher frequency or not consider this just as redundant data. Here's a new epoch. There's a couple other strategies beyond those that he's working on for tackling those issues of how to chunk the data, sample from them, and figure out what to bring into the CDM, since you can't really handle, if you've got very high resolution data for days and days and days, it's not feasible to have something that you can compute on at the end. And if you bring all of those in, and you don't need it. So that's not a resolved issue, but he's got a strategy for it that we're working on. And that gives a sense of what that looks like from the WFDB format, which is not just used by Mimic. It's been, I think there are various device companies that are also using it because, I think, of Mimic and so forth. So it's good to become familiar not only with that format, but with the tooling associated with it that's been developed by the PhysioNet community. And here's the label for a table that has a set of labels for different ECG features. And the OMOP concept ID, the third column in here, just represents for each of these things what the OMOP concept ID is, and the label for it is next to that. And then the OMOP concept ID for the units and the label for the unit is next to that. So this is actual output from some of the processing done by that overall workflow that was sketched in the previous graph. Gives you a little more concrete sense about what comes out the other end there. Any questions on that before I move on to the neuropsychiatric scale data?
I had a quick question, Andrew. This is exciting. Do you see this signal data can create so much more useful information for OMOP, but do you see that hopefully this also could be maybe reduce some of the transcription work that nurses need to do? I know they need to do context and review the data, but maybe it'll help in having to, they can spend less time just transcribing data from the devices.
I don't know that this work will do that. We're relying on things that do that for us so far. I think they're going to be things that annotate in a more sophisticated way than nurses would typically be asked to do, granular features of things, or clearly identify things as artifacts, handle alarms in a specific way that are needed for research, different than their function in the clinical context, et cetera. I think the automation of that is going to be moved forward by a lot of a lot of the tooling and analytics that are going to be brought to bear in this Bridge to AI proposal project are going to handle that. I'm not sure how much of the burden, if there isn't a solution already in place to automatically get that, how the work that we'll do there will relieve them of that. But I'd be eager to hear. It's an important issue. To me, it seems like a device manufacturer issue rather than a research analytics and informatics issue. But I would love to hear your thoughts on that.
And the other side of it is that what the use cases you showed were all clinical acquisition telemetry challenges, but for the model that you've helped implement, it's equally valuable and sometimes more valuable for OMOP to be capturing Fitbit and waveform data off of IoT devices for tracking ambulation and recovery times for patients. So the same model supports both long-term physiological monitoring as well as these high-frequency short-term sensors too, right?
It does. Yeah, it should. And yeah, we're doing some work on that with a couple other partners outside of that in a different space. Yeah, I think the same overall approach is needed and the same overall approach works. It's a little, some of the other, I'm not going to go into the details of it. OMOP and a large database that's got comprehensive data aren't always present and aren't always needed. And some of the other projects we're working on where this might be applied, it isn't needed. And so we don't want to use it to put a square peg in a round hole. And so finding out which pieces of this overall process and strategy are relevant when you don't have a ton of other clinical data that need some sort of standardized representation, and where to pull out the successful and useful parts of data normalization and related workflows is part of what we're doing there. But there is definitely a strong connection in a lot of cases where you have people who are in inpatient or outpatient settings, and which ones are wearing which devices, and the data that came from those devices as mobile devices, then it's clearly very relevant. The broader space of wearable devices encompasses a lot of cases where you don't have that, and so the rationale for an entire CDM is less clear. But yeah, it's definitely applicable very broadly, just as you said. So the next category, I'd love to introduce to you, Chris. I'm not sure you knew this, but there's a psychiatry work group in Odyssey I helped to co-lead, and Piper Rinaldo, who I know you've worked with, is a member of that group, and we're working on some things with her. I think she shared with me that I think you and she are working on some of the same issues that came up in the group.
Yes, I remember Piper very well, and I'm delighted. I did not know this is going into OMOP, but I'm delighted to hear that.
Yeah. So what's already been done by this psychiatry work group that I co-lead with Dima Demschetz, who works at Odysseus Data Services, or did. He's now been hired at Janssen, but he's been part of the core team that handles OMOP vocabularies, or leading it actually for a long time. He's a psychiatrist by training. We did a survey amongst the data holders that are regular participants in the psychiatry work group to see what kind of scales and subscale scores they have available in their EHR settings. And many of these were in Europe, somewhere in Asia. Dima and his team went through that and developed standard OMOP concepts for 206 scales and subscales as sort of a proof of concept. We want to do a wider survey of what other data holders have, what people think are most important to have, et cetera, and continue this. But did this already for 206 scales and subscales, including the ones that are listed here, the Adverse Childhood Events scale, ACEs, other very commonly used scales, BPRS, positive, negative symptoms of schizophrenia scales, and their subscales. And what that's going to allow is just much more granular information. I spoke earlier about how, as a psychologist, I'm really interested in understanding, for example, if you have medication that's meant to affect or help people with schizoaffective disorder of some sort, what is it actually affecting, right? You kind of, all you typically have, if you're not going into fairly complex analyses of notes from whatever psychiatric unit they're in, you just have diagnoses, and whether people's prescriptions have changed and how long they stayed in a unit, whether they have symptoms the next time they come after they've been discharged, but not details in ways that are really extremely important to understand. So, for example, some medications might, for schizoaffective disorders, might affect positive symptoms more than negative symptoms in ways that aren't really very well understood, that didn't come out in the trials of those things. And we have an opportunity when we start to collect these and get a much more granular understanding of phenomenology of what people are experiencing with behavioral health, mental health issues. Just a much more nuanced understanding of the impact of therapies on them, as well as how these things change over time, but just all of the different things you want to do, characterizing the effects on their condition, the natural history of it, all the sorts of things that you want to do are just aided by having this much more granular representation of that phenomenology than you would get from just the diagnosis code. So that's the larger rationale, and we've made some initial headway on that. And prior to Piper joining, Dima had already started to work with folks that Odyssey typically works with at SNOMED on adding concepts for these things. There's a broader set of things that I think relates more to the work that you've been doing with Piper and others, Chris, which is kind of revisiting the top level entities and hierarchy for behavioral problems in physiological or non-mental health diseases. Those top level entities of morphology and sight are, the highest level, and the descendants of those tell you the specific site and the specific kind of morphology and some qualifier typically used to characterize something. And that's less apt in something like mental health issues where you don't necessarily know an anatomical site, and the theory linking neurophysiological substrates of behavioral issues or mental health issues to what's manifested in the clinic is not very clear. So there's a challenge to both perhaps reconfigure this at a very high level, what the parent entities ought to be and what gets subsumed in them and how, but also to find the place where our current understanding of the neurocognitive basis of mental health problems meets what might ever really get measured in the clinic using a scale or interview or whatever, and where there's enough agreement about those things that it isn't likely to change 5 years from now. So it's the ontology and representation challenge has a couple of different dimensions to it. One is, what are people actually going to be able to measure because it's useful, and where is the current state of knowledge likely to be stable enough, and at least for some foreseeable period of time, that it makes sense to start grouping things according to different categories like sensation and perception, or attention and memory, and different subdivisions of those larger categories. Where do you stop? Because there's enough agreement that those things that you're starting to name in your ontology, or for processes and functions, are stable and agreed upon. There's an effort that's been underway at National Institutes of Mental Health for a number of years called RDoC, which tries to do something very much like that. It isn't focused on clinical data in any way. It's really focused on research data, but the gist of the idea is to ground descriptions and ontologies based on what's known about the physiological substrates from a cellular level up to the nervous system and to behaviors and so forth. And a lot of work has gone into it. It's hasn't been an extremely stable and unified effort, which makes sense given the complexities of what they've dealt with, but it's got that similar intent. And some folks from RDoC both have been involved both at LOINC and at SNOMED in helping to think through some of these issues. And so we're actually thinking about trying to convene some people who really understand both the ontology issues and the clinical issues around this as part of what we're doing in the psychiatry work group, and propose something that might get adopted and help affect in general how these things are being done. That's a longer term goal. The shorter term goal is to carry on with this understanding of what data are typically available, and developing concepts that can be queried and used as to get a more granular picture of the data. The role of LOINC is probably more to do with individual item level data than it is for the scales and subscales, unless we change tax. But it's clearly not, individual item level data is clearly not something that would be there for SNOMED. But individual items can be very important, especially if you got things like symptom checklists. You might have something that's just 10 or 11 items in a particular scale, but each one of those things is really distinctly important in its own right, and would really be great if you knew it was there or not, even if it's only measured by a single question. Some of the use cases for that are some I've already gone into, the symptom level impacts of things. Oh my gosh, we're already at time.
Yeah, we've got a minute or two to wrap it up. That'd be fine.
Well, there's a lot on place-related data. That's really one of the things I'm most excited about. We've developed, I'll say, gotten pretty far recently on this sort of generic process for getting and transforming arbitrary kinds of data such that they are ready to be integrated into an OMOP system. We've got sort of rough working code that does this, and schema for representing history of locations, sort of the entire exposome people might have had, and not just a single static residence. And we're ready to start engaging more on the vocabulary front for the standard representation of the concepts once these place-related attributes are brought in. So we've got both a schema and some working code for all the functions that do some of that work. That's the only thing else I wanted to cover. I won't go on too much longer. Gosh, it snuck up on me. I didn't leave any time for questions, but you were asking questions as we went along, so I guess that's good.
That worked out just fine. That was great. I do want we will dive in deeper to GIS information, and I think you're right that the key is that people move, and so in some ways you want to be able to track that to understand how the different exposures that they've had or the environments they've been in can have an impact upon their health. And so I think that's going to be a welcome addition to the OMOP vocabulary. So with that, I want to thank our Grand Round speaker, Andrew, for talking about different areas and I think those are going to open up whole new areas of questions that we can ask with the OMOP data by going deeper with more granularity into time series, by going wider into GIS and social determinants of health. I certainly see, trying to figure out how we keep standardization around this. Again, multiple sites will be interesting, but I think we're going to start seeing this. A lot of sites going much deeper into their data and other sites going wider. And so it'll be an interesting challenge for some of the network studies that we're hoping to be able to accomplish over the next couple of years. But it certainly is an exciting time where we're really taking advantage of a lot of the data coming out of our clinical systems. So with that, I'd like to close our Grand Rounds. I want to thank our speaker again, and I look forward to seeing everyone next month for our next Grand Rounds. Thank you, everyone. Have a great day.
Thank you.